My name is Tessa van der Willigen. I'm a board member of HA, and I am your facilitator for this session. And I would like to start by thanking all our sponsors for making this event possible. We have to keep remembering that because this would not be happening without them. Our experts are going to speak for about half an hour. That's their plan. So we'll have about half an hour for Q&A. To ask questions, I would ask you to fill out the note cards that are on the chairs and pass them to Annie, who is sitting in the front row there. She'll be roaming around and collecting them. We will only take questions in writing in this session because it is being recorded for broadcast on the website later, so we want to preserve people's privacy. So I'd like to introduce our speakers. I think Dr. Williams is going to speak first. Mike Williams, most of you know him. He is one of the medical co-chairs of this conference. He's a member, actually the vice chair of HA's Medical Advisory Board and a member of the board of directors. And of course, he is from the University of Washington School of Medicine in Seattle, Washington, recently of Johns Hopkins, where I think he left about 6 months ago. And then his co-conspirator, Dr. Mark Luciano, still from Johns Hopkins in Baltimore. So I'm going to hand it over to them. I think Mike is going to present a broad overview, and then Mark will go into some more specifics, and then we'll open it up for questions. So thank you very much for being here.
Thanks very much, Tessa. Good morning, everybody. So it sounds as though Dr. Luciano chased me out of Baltimore, and that's actually not what happened. I had left Hopkins about 8 years earlier, and I was at another hospital in Baltimore for a while, and it just so happened with timing that as he came to Baltimore, I went to University of Washington. But we've been working together for many, many years, have shared patients of all ages, and like very much working together as neurologist and neurosurgeon. So my goal this morning is to give you my perspective as a neurologist, and you all no doubt know that most of the experts in the field of hydrocephalus are neurosurgeons. So there are very few neurologists around the country who know anything about hydrocephalus, and it's not because they're ignorant in a bad way, they're ignorant because nobody ever trained them. And so, in fact, that's something that I'm working on with others at our National Academy meetings. So, for example, last year when our Academy meeting was in Washington, D.C., I had Dr. Luciano on stage with me, and we presented together as neurologist and neurosurgeon to an audience of neurologists. And then this year in Vancouver, British Columbia, Dr. Mark Hamilton, who's the neurosurgeon from Calgary in Canada, did the same thing with me. So, but neurologists, even if they don't know a thing about a shunt or how they work or much about hydrocephalus, still have a very important role for you. And that's because neurologists are trained in the art of what's called differential diagnosis, which is to first say, well, what could it be among many things? And in fact, one of the problems that often occurs if you go to see a doctor and you have a shunt is that everybody gets tunnel vision. All they see is the shunt. You go in and your elbow's hurting, and they call up Dr. Luciano and they say, Dr. Luciano, could that be the shunt? And he's going to roll his eyes, but nobody will see that because it's just on the telephone. And then he's going to say, no, I think you might want to send them to an orthopedic surgeon or something like that. But that's what happens. And so a lot of my job as a neurologist when I care for adults with hydrocephalus is to ask at the same time, well, what if it is hydrocephalus, but also what if it isn't? So we want to teach you to do the same thing. And you may see a neurologist at some point who gets this tunnel vision and say, you know what, it's okay if you don't know how to manage my hydrocephalus, but you can help me to figure out what if my symptoms are something else. So that's a really powerful question for you to have. Now, I moved from Baltimore to Seattle last November, and I've been working at the University of Washington over the last 6 months, seeing all adults, anybody 18 and over. And I've learned quite a bit, and because Seattle Children's Hospital is the only children's hospital in the region, many of the young adults are coming to me now. And many of them are transitional patients, but I'm seeing patients who might have made that so-called transition years and years ago. And fortunately for most of them so far, it's checking in, establishing a relationship, and they're not having active hydrocephalus issues. A couple of them have, and we fortunately have dealt with those. They haven't been too hard, and most of them so far seem to be happy to have services because there was no organized program for adults before that. The process was to sort of go to the next available neurosurgeon in the queue, and that doesn't always work out well, and now they've got a place to call home. Now, that's a pretty scary looking diagram, and this is a diagram that comes out of the field of what's called transitional care. And transitional care ideally is a process that starts when you're younger, ages 12 to 14, and gets you prepared to leave the pediatric health system and to enter the adult healthcare system. Now, this session this morning is for adults with congenital hydrocephalus, so many of you would have fit this definition of requiring transition, but it's also for first generation, and first generation is our shorthand way of saying somebody who got their shunt in the 50s, the 1950s, or 1960s, or 1970s. So this process goes between ages 12 to 20, and if you're in that first generation, and perhaps even if you're not, this is what should have happened for you but didn't. Now, some of you may have just been bid a fond farewell, or maybe no farewell, and you're sort of left out there in the lurch. But this is what I think is really important. The whole goal of transition is to go from one state to another state, and that's the transition completion, ongoing care. I forget why it says consumer feedback down there, but ongoing care. I get lots of consumer feedback in my clinic. So this is a notion that I have been promoting for a long time, and quite simply, when I see an 18-year-old with hydrocephalus, my goal is to get that person to 80. So the pediatric neurosurgeons have them for just shy of 20 years, and I get the next 60. Or so to help to get you there. And my vision is that every patient with hydrocephalus at every age and every stage of life should mature and advance successfully to the next stage of life. That's what you deserve. That's what you want, to mature successfully. That's the ultimate goal of transition, which is to have this team of physicians and other healthcare professionals whose role and goal for you is to keep you well so that you can live that full life. This is what's important. So you're going, team? Who is this team? Because you may not have a team. And here's my suggestion of who it should be at a minimum. Well, you have hydrocephalus, you may have a shunt or an ETB. By definition, you need a neurosurgeon. And you should have a relationship with a neurosurgeon. To go years and not have the relationship puts you at risk of having something quite sudden happen, and you go to the emergency room and the neurosurgeon who's on call and sees you doesn't know anything about you. So that's not the best circumstance. Next is I'm going to suggest that you also ought to have a neurologist for what I alluded to earlier. You may have symptoms that are better managed by a neurologist. They're not surgical, they may be more medical. Or again, to answer or help you with the question of, is this symptom the hydrocephalus or the shunt, or is it something else? Now, the other thing that happens to you as you get older and you mature is you get the things that all the rest of us get when we get older and mature, and whether that's hypertension, or if you're young and building a family, you may go through pregnancy together, and I'll say that together because although the woman carries the baby, and that's the hard part of the job, the husband is going through his own set of anxieties. Or you may be getting older, you may be hitting retirement age. and so forth. So you need other specialists, and that could be a diabetologist, it could be a cardiologist, could be a rheumatologist, all those things. So that's your team of physicians. So what are some of the adult issues? And I'm a big proponent that you should see a neurologist or a neurosurgeon at regular intervals, even if everything is fine or stable, if we prefer to use that word. And the reason for that is because you may be slowly and very subtly developing symptoms and changes that, because they are so slow and subtle, you don't notice. But because I, as a neurologist, may see you once every year or once every 2 years, those subtle changes may have accumulated enough that I can see and document a big change, which is a tip-off to me that something is occurring to you. So this is a little bit like a health maintenance approach for your hydrocephalus. And I've had patients who, because of when they made that transition from first generation, who went decades without seeing anybody for their hydrocephalus, and they came back and they had been developing symptoms for years and never knew it. And sometimes that can be too late by the time that they reach us. So as tempting as it is to say, well, I'm young, I'm healthy, I'm okay, I don't need to see a doctor, you do. And please don't make the mistake of going for years without seeing your hydrocephalus expert. Now, the next question that we often get is, well, what if everything is okay or stable or I'm asymptomatic? And even in that circumstance, I would advocate that you should still see somebody on a regular basis. And some of the adults that we see don't have a shunt or don't have an ETV, and they're quite well. And I think it's important to see them periodically. And if you do have a shunt or an ETV and everything is stable, we should do the same thing. Now, the other thing that occasionally happens is somebody comes in and, you know, the last time they had an operation on their shunt was 15 or 18 or 20 years ago, long period of time. And everything seems stable, and they say, well, is my shunt working or my ETV working? And you're going to think I'm a little crass when I say this, but I'm going to say to you, well, what does it matter? Because to answer that question, we'd have to do something invasive with a shunt. We'd have to do a shunt patency study or something else. And the fact of the matter is, if you are well and you are stable, one of two things is happening. The first is, yes, you still have hydrocephalus that's active and the shunt is working. And the second is, well, maybe the shunt is blocked and you're stable anyway. And since we wouldn't change anything by answering the question of whether the shunt is working, the best approach is to leave the shunt or the ETV alone, but still to monitor you on a regular basis. Because the way that we find out whether you're changing is to see you on a regular basis. Now, the next question, and I know Mark is going to cover this in his talk a little bit more, is whether shunt or ETV failure when I'm an adult is the same as when I was a child. And the answer is occasionally, but not always. In fact, mostly not always in my own experience. How your brain tolerates shunt obstruction or ETV obstruction may be more subtle or insidious in onset rather than acute, but it can be acute, and it really depends on individual circumstances. So one of the questions that I ask young adults, and sometimes their parents who are with them when they first come in to see me, is, what was it like? What were your symptoms the last time you had shunt failure? So that I have an understanding of what that known shunt failure looks like and can help to look out for that in the future, but also to know that it could be different and to help them to figure out whether that's the case. Now, what if I'm symptomatic and you're hearing this for the third time, and it's because by the third time you hear it, it's going to stay in your mind. Not all symptoms that you think are from hydrocephalus are from hydrocephalus. And again, that's the role of differential diagnosis, simultaneously to ask what if it is and what if it isn't. And I know that it can sometimes be a challenge for you to go to that doctor who's not a hydrocephalus expert and to get them to think that way. But if you develop a good relationship with them and say, you know, it's okay if you don't know what to do with my shunt, but let's figure out what if it's not. Now, probably the other very common issue that we see is headache. How many? Lots of hands. And I've been taking care of adults with hydrocephalus for 25 years, and I know that this is the most challenging symptom that we face. And for you, probably the most, or one of the most dissatisfying symptoms that you may have. And not all headaches are shunt related, but they can be. And again, by working with a specialist who knows how shunt works and who knows how to figure out, do we have high pressure or low pressure, we can see whether working with a shunt system can help with that. But the funny thing about headache physiology is that it can take on a life of its own. So even if you don't have hydrocephalus and you just have migraine headaches, for example, some people have a migraine headache 3 or 4 times a year, but sometimes that process accelerates and they get what we call a transformed migraine, which is turning into a chronic daily headache. Or the other thing that occasionally occurs is that, well, I've got a headache, I'm going to take some analgesics, some pills, and oh, I still have a headache, and all of a sudden, through no fault of your own, you're taking a pill for your headache because that's what we all do. But that can build up, and you get this very funny and paradoxical syndrome that's called rebound headache. You try to go without the pain medication, but because your brain, the pain receptors of the body are sensitized, so to speak, to the analgesics, when you try to come off for a good reason, because you want to try, well, it hurts. And you say, okay, that's not working, I'm going to take it again. And so you're sort of caught. You can't get off that medication. And that's called medication overuse headache, or sometimes rebound headache. And I am not an expert in headaches. But I'm fortunate at University of Washington that one of the headache experts went out of her way to contact me and said, how can I help you take care of those patients? So there are medical ways of management, and there are adjunctive therapies that we can look into and try to offer. And I do have some thoughts that I'm hoping to work on in the future about my belief that I think how we treat children with hydrocephalus may set the stage for creating a chronic headache syndrome, and what are some things that we could do in working with the pediatric neurosurgeons to forestall that. So this is the end of my talk, and Dr. Luciano is going to take over and present his, so I'll sit politely and watch his talk just as he's done for mine. So thank you, and then we'll have the questions in just a few minutes.
Thank you. Thank you. I was actually trained and have practiced pediatric neurosurgery for 20 years at the Cleveland Clinic. And I was actually director of pediatric neurosurgery and pediatric neurosciences. But I learned very quickly, because the clinic set up as the children's hospital is right there with the adult hospital, that there is this gap that Dr. Williams is speaking about children who grow up and fall off the edge of 18 years. And need help. So we very quickly, actually in the second year I was there, we renamed our section pediatric neurosurgery to pediatric and congenital neurosurgery, meaning we treat people of all ages with hydrocephalus. That also opened up the door to adult hydrocephalus, of course, first generation, and normal pressure hydrocephalus. That's one of the principles that I think has been very important, to see the full spectrum lifespan of hydrocephalus and see how the pediatric neurosurgeon can help forestall often some of the problems in adulthood that he may not even know exist, like slip ventricle syndrome, small ventricles, overdrainage for years, which can be treated even very early before it becomes a problem if the pediatric neurosurgeon knows about it. So this integration over the lifespan is a very important factor. Another important thing that I learned is teamwork. You know, I'm a neurosurgeon, but we have to have the team that Dr. Williams described. And I was developing that at the clinic, but saw more recently, and I've been to Johns Hopkins for about 8 months, with the opportunity to build the sort of team, multidisciplinary team, and research to bring this sort of concept forward. So that's 2 very important evolutions in transitional neurosurgery and helping kids grow up to adults and live for the lifespan with hydrocephalus. Those are my disclosures, which are none for this talk. And we know that the impact on the lifespan in hydrocephalus has multiple dimensions. I mean, it's how a person functions, which I'll just touch upon in the first few slides. It's financial. from the perspective of the patient and the hospital and society, and so it involves personal growth and social impact. So there's a lot of dimensions to what happens as a person grows up with hydrocephalus. I'm going to touch on one paper review just to remind us of what can happen as a child grows with hydrocephalus. This is just a good paper which has 546 patients. They started with over 1,900 patients, and they tracked how they did. These are patients that were followed for about 2 decades, 2 to 3 decades. And so they were followed from childhood to adulthood. And basically, the results were that many children are living, which is excellent news for all of us, and that didn't happen before the onset of our treatment of hydrocephalus. It also seems that many patients need their shunts throughout their lifetime. Only here in this study, and it's consistent with some other studies, that shunt independence only occurs in a minority of patients with hydrocephalus. So these are patients that survive and continue to have hydrocephalus, continue to need help with shunting. It's also clear that that there are some deficits in some of these patients. This is just a graph showing the first time a person had to have an operation, or the first reoperation, I should say. And you can see all through the lifetime, in the 20s, there's a period of reoperation that occur, but also it starts leveling off. But there are operations that occur in every decade that they followed. The lesson here is that as we follow hydrocephalus through decades of life, an acute problem, a shunt blockage, can occur, unfortunately, still at any time. And there are many reoperations. This says, well, a large proportion of patients may have multiple operations. Here you see up to 5 operations, but it can trail off to some having many more. In some of the tertiary centers that treat a lot of hydrocephalus, we'll see patients with 14 operations, 30 operations, and more. However, there are, optimistically, 20% of patients who have had no shunt revisions. So obviously, one of our campaigns at Hopkins, and really probably throughout the country and world, is 1 shunt per person. Let's see if we can get a treatment that lasts. But the average is 2.7. Interestingly, 5% of the first operations on a shunt is after the age of 20% in this study, which means the pediatric neurosurgeon never really even experienced any problems with that shunt. But the other neurosurgeons later on in life, the quote adult neurosurgeons, might have. In terms of function, you can see that these are gross scales of a person's general function in daily life, and 80, 90, and 100 means that you are independently living, and roughly 53% are independently living. There are multiple kinds of deficits: motor, cognitive, behavioral, and you see them listed here. Pain, as we mentioned, in terms of headache as well, and other things. And however, 18% have none of these, but that means over 80% do have some sequelae of their hydrocephalus as they go forward. And finally, as rough ideas of how a person is doing, the good news is that 54%, 41%, 33% have high or acceptable or higher IQs, normal schooling, and normal jobs. But that does mean that the glass is half empty. There's a lot of patients that don't, and we have to obviously try and optimize their care, starting with pediatric care and continuing out throughout the lifespan. So what are the long-term problems? Now, a lot of what we see in pediatrics, and you all know from pediatric hydrocephalus and shunting, still persist, although to different degrees in adulthood. But adulthood carries some different issues. For example, Mike covered well, and I won't elaborate on it, but chronic headaches, which take a life of their own on, and may also involve cycles of medication use. These become problems for a great proportion of our adult hydrocephalus patients. At the same time, because regulation of CSF drainage through a shunt is not perfect, it's not physiological, it's not the way our bodies would do it, that over time, in many cases, the person may be slightly overdrained, and we end up with patients who have very small ventricles. Very hard to maintain fluid drainage when the ventricles are, quote, slit, when there's not much there to drain. Yet, drainage has to continue. There's also patients with relatively big ventricles, and you look at that and say, well, that person may need even more drainage. But in fact, they too are overdrained, and these people can have symptoms that may be not even discovered, because we feel, well, we're not overdraining that person. Their ventricles even are still larger. Sometimes I see those patients, they've had several shunt revisions to make the patient have more drainage and fix their shunt, when indeed already they have too much drainage. So that's a problem with some of these long-term patients. Of course, and we get this all the time, this question of, and nothing against GE refrigerators, but is there an expiration on this shunt? If it's 5 or 10 years old, should we replace it? And I always say, well, no, this is not any planned, this is not like a refrigerator that will become expired or planned to be obsolete in so many years. I guess that's true now with Apple computers more than GE refrigerators. But it is true that the plastic does age. It does become somewhat more brittle. As aging occurs, there's of course stretching with the initial growth, and there's calcifications around the catheter which make it brittle. Bottom line, it is more prone to break mechanically as it ages. But there is, generally speaking, no time at which we say, this shunt is old, you're doing fine, let's change it. That we never do, because they can last for decades and decades. Interestingly, we know with shunts that bacteria behave a little bit differently. They have a little place to hide inside the plastic, outside the plastic, in the little grooves of the plastic. They hide on the inner wall of the shunt where there's only the CSF fluid, which is a nice medium, and they can live there a long time. And by that I mean even years. And there could be insidious infections which occur over time. I should be clear that many shunt infections occur within the first 3-6 months and within that shorter framework. However, there are also infections that we see, and there's some people that have retained catheters that continue to seed infection. So we always are concerned if there's signs of chronic inflammation in a patient who has multiple operations and multiple retained catheters. And of course, and this is the point I made earlier, that even over years, as a person is doing well, there is still, unfortunately, the chance that an acute failure, acute breakage or blockage can occur. And even though it's been years, all of a sudden it becomes something that has to be attended to expeditiously. And for the surgeon, there are specific problems in some adults with hydrocephalus who have had many operations. They may have many fragments of catheters. They may have 2 to 3 catheters with multiple sites of collection and so forth. This, to a neurosurgeon, especially those who aren't used to dealing with hydrocephalus, can be a pretty vexing and complicated problem. They don't know which to treat, how to treat, what to remove, and what kind of shunt should go in. There may be scalp incisions which make the scalp very thin and tenuous. So often, from a surgical and medical standpoint, the surgery itself can be more problematic. And for that, a specialist who deals with this is often preferable. So just to touch upon this very quickly, often in child neurosurgery and neurology, we are quite accustomed to dealing with a child with well visits every year. This doesn't always happen and doesn't often happen in the adult world. And it varies, as I've seen, from PRN, come to us if there's a problem, to yearly visits. And of course, the variables are if you've had acute events, if you've had symptoms or not. But it also depends on how you think the patient might be introspective or have family members who are watching, how closely you have to watch that patient. However, it's true, as Dr. Williams has mentioned, that you need to maintain connection to your neurosurgeon, and I'll add to that to the whole team. They know you before you get sick. It's very important to do that. They know you from the past. Sometimes, for example, when I'm going down to Hopkins, I'm having patients see me. I'm doing fine. I just want you to see me, talk to me, and have the images available should there be a problem in the future. And that's a good idea. And of course, have the images available if they haven't been done in a period of time. And this is an important aspect because it goes back to the idea of teamwork. Many times, the neurosurgeon plays a very strong role in a crisis of a shunt obstruction. And we're happy to do that, and that's what we do. And we're also honored that it also often creates quite a bond between the neurosurgeon and the patient. And that's the way it should be. We should be available in emergency visits, in the clinic when you need us, and by telephone calling us or our office. And that's the way it should be. However, I still believe that the best care overall is when you have a coordinated care by a whole team, and that includes neurology. It can include geriatrics if it's that point in the lifespan, and we have neuroradiologists and other aspects. And that whole team is very helpful because I'll admit it, as a neurosurgeon, we have our focus narrowed. It has to be, because we have to think about the shunt and what to do with it. And we bark up one tree. Well, neurologists, they're a different kind of dog. They bark up lots of trees. And that is helpful, and it can be essential. And so, as a team, yeah, that's right. So those both approaches, focus and depth and knowledge of the differential, as Mike said, are both essential to good care. When to seek help? Well, some things are obvious. Progressive headaches, things which are getting worse. I think you all know signs of pressure, nausea, imbalance, can be visual problems. You don't have to have all of these, but you have to have some of these with progression that feel like you have pressure in your head. The best person sometimes, most of the time, almost all the time, that knows that their shunt is failing and that they're having problems is the patient. Or in pediatric neurosurgery, it's the mom. And so we teach the residents to listen to mom. I don't care even if you're a second-year neurosurgery resident, you still listen to the mom. They know what failure is like. So sometimes you just know. Sometimes you feel okay, but you're not worried about so much yourself immediately, but you're worried about your shunt. You feel it stretching and pulling. Well, that can happen as we get older and grow and have calcifications. It isn't always bad. Sometimes you have to come to the clinic and get x-rays to make sure it's not broken, but that may be all that's needed. Sometimes it's broken a little bit and we're not sure if it's even working. As Mike said, that may not be anything you have to do anything about. We still watch clinically. Trauma, of course, sometimes you can hit a shunt and worry about it causing a break. I will tell you that the shunts generally are pretty darn tough. If you get a baseball to your head, or if you get something that hits it directly, I'm still kind of more worried about you and your head than I am about that shunt. But we can obviously get an x-ray and take a look at it. Magnetic fields I'm going to touch upon a little bit later. In this world of programmability, adjustability, we have to worry about what magnetic fields that we're in, and I'll talk about that more. This is something that always amazes me, that I sometimes get a visit from a patient who said, yeah, I've had feels like a little indentation there for weeks or months and so forth. And I look in and I see what we dread, and that's a little white dot at the bottom of a wound, which means the plastic is right there and exposed. If that plastic gets exposed, that means bacteria from the world has touched it. We have to remove it. So the idea there is when your skin is getting thin, or when some parts begin to be exposed or thin, we need to see that person before we see that white dot at the bottom of the hole, before it gets infected and exposed, so we can just revise some skin and put it over with, as opposed to taking out the whole shunt, giving antibiotics and putting one in. So that's the time to come see our team. Headaches, Mike talked about quite well, and I just want to say that at the same time I say you listen to the patient and the patient knows. It's very hard to distinguish between headaches. Headaches are really tough. That's why there's a whole specialty about it. Some people say, oh, this is my under drainage headache. I'm not, well, they don't say it that way. They say, I'm not draining enough. Pressure's building. Or they'll say, I could tell I'm actually being overdrained. I know, and I know the difference. And you can sometimes know the difference. We classically say when you're up and you get bad headaches and dizziness, it's probably overdrainage. When you're laying down for a period of time and pressure builds up, then it's under drainage. Well, those are oversimplifications. And migraines, the flu, other illnesses, those other trees that you must bark up are also possibilities for headaches. And it's not so simple. What we often, or I shouldn't say often, but sometimes have to resort to is placing a pressure monitor and see if the person has high pressures or low pressures, or in a sense no pressures. One of my nightmares, one of the things I really don't want to do, is operate multiple times on a person's shunt and get it working, when if I knew they had normal pressure from the start with and their headaches had nothing to do with pressure problems, we would have gone right to the proper treatment of headaches. So that's important, and that's also why the team approach is important. Where to go? Well, if it's chronic and you've got time, obviously it's best to come to the neurologist at the neurosurgery clinic visit. And for us, it's the Hydrocephalus clinic, which has the various multidisciplines. If it's acute, in other words, this is something that's happening, but not progressing, you should probably go to your hospital. By your hospital, I mean the one that's treated you, the one that your neurosurgeon works out of. That's obviously preferable. However, and this is the key thing, if this is acute and progressing, you must get to the nearest emergency room. From there, we are usually on call, if you will, from the physicians there to talk about your shunt problem, and they can stabilize if that need be and have you transferred to us. One of the things that's disturbed me is when, and this was from the pediatric side as well, a child was getting sick, getting lethargic and having a headache, and the mother's frantically driving 2 to 3 hours to come see us, and at that time in Cleveland, for example. We shouldn't do that. You should go to the nearest emergency room, whether you're a child or adult, and have them take a look and assess. Most major hospitals can stabilize a patient with hydrocephalus, and then your team can take care of the long-term solutions. Well, the emergency room, how many of you have had some emergency room blues? I mean, been there for hours, gotten yet another CT scan. I just had one last week, and I've had 5 in the last year. And sometimes those are necessary, many times they may not be. It's all because care is not so well integrated, and emergency room people have to run their protocol and rule out the worst things, so they do these studies. They also, though, don't have the comparison films. I can't tell you how many times I get a call from emergency room, so-and-so's here, has a headache, and the hydrocephalus, has bad hydrocephalus, ventricles are big. And they have no comparison. Indeed, the ventricles may be a problem, there may be recurrent hydrocephalus. But if you go back and look at our comparison films, we find that their ventricles were even bigger 1 year ago when they were doing fine, or maybe the same. Or they may indeed be bigger, and yes, we have evidence of shunt dysfunction. So comparison is key. And I'll add to that, when you see another doctor, a lot of people like, I won't bring the films, let them get their own films. When you see a neurosurgeon or neurologist, in this case of this chronic disease, we really want to see the history, the older pictures. We want to follow if we can, even before it was first treated. What did the hydrocephalus look like? What did it look like when it was shunted, when you were feeling good? And what's it look like now? That really helps us get the whole picture. So fill up your glove compartment with the discs, or if they're films, if they're old, put them in the back of the trunk and take them with you. And don't worry, if we need to get more films, we'll get more films. But it still helps us to look at the old ones. In the emergency room, we're dealing with well-meaning and very smart emergency medicine physicians, but they don't know about shunting. And I've gotten calls saying, I pumped the shunt, it seems to be fine. Well, I'm thinking, I know what that shunt is, and you can't even pump that shunt. You can't pump that shunt, I know you can't. And even shunts that you can pump, you really can't always tell that much information when you do that. So when they say that, I know that they aren't familiar with the system, which is okay, but it's not okay in terms of getting the optimal care. And this is what can happen even in emergency rooms where we work. There can be difficult shunt or lumbar taps. There's a lot of different shunts out there. Some you could put a needle into, some you can't. There's some that have an area, you should put a needle into it. And on that same shunt, there's an area you shouldn't put a needle into. And usually it requires a neurosurgery service, and hopefully one that knows and is familiar with that anatomy. To do a shunt tap properly. Very often in the emergency room, a shunt tap is, besides imaging, one of the things that will be done to evaluate the system. And I think all of you have known that, and many of you have had shunt taps. Let's talk a few minutes about traveling, because we get this question a lot. Can I go up in an airplane? And the answer, generally speaking, is yes. In a commercial air flight, I mean, if you're in some sort of a non-pressurized chamber where the pressure changes are really great, like your NASA flights maybe, then that's different. But a commercial flight usually does not have the pressure changes which cause at least a significant or permanent problem. But airplanes with that change in pressure, or even going from Denver to Mississippi, can cause some problems, some changes in the headaches. And we have seen this. And I guess what we have to say is it's usually symptomatic and goes away. On some occasions, it means that we have to adjust our shunts. We've gotten questions about diving, and the general opinion about diving is don't go deeper than 30 feet. And I'm not sure where that came from. Do you know where that came from, Mike?
I have no idea, but there was a review article that was published last
About diving?
Yeah, about diving. I haven't had a chance to read it
Okay,
yet.
we'll give you an update on diving.
But the real issue is never dive alone.
Well, that's a very good point. That's a good addition. Airport security, with the new adjustable shunts especially, there's always concern, will it change my shunt? It should not change the shunt. It does not have the magnets that are arranged in a way that can do that. But if you have a medical card, also if they see a lump or detect some metal, that should help you get through. We rarely have a problem with people going through airport security. And this, I think, requires some emphasis. When a person has a lifespan with hydrocephalus and has had many surgeries, it can be very difficult when you see a new physician for him to put it all together. I would encourage all of you these days with computer files and so forth to keep a running record of the operations when you had them, what was done, and why it was done, and perhaps even what happened. Keep a running record, keep it on your computer as a file, because whenever you see a physician, I could tell you from being on the other end and having to see 20 patients in a day, how wonderful it is to have a summary to understand in a new patient what is going on. Because again, this is a situation where there are complex issues in a complex history. It's difficult to expect thorough care when it's hard without spending an hour or 2 hours just looking at the record, extracting that kind of information. So help your doctors in any way you can. You know, these days we can keep a word file. Also, always have a copy of your own CD with you. When you get an image, do not trust the hospital to say, oh, you'll send it to Cleveland Clinic, you'll send it to Washington, you'll send it to Hopkins. They often do not. Or if they say that they're going to send it, they'll send just the report. They won't send the CD. So the best thing to do is ask and get a CD of your imaging, past if you can, certainly the latest, and have it yourself to bring to other people. Also, with respect to traveling, if you go somewhere, especially for an extended period of time, you might want to have that in your glove compartment, because remember I said, comparison is important. If they say, oh my God, the ventricles are big, you say, look at 2 years ago here. And so that's really, really important to give a CD. And also any information on the local hospitals where you've been treated and the specialist contact. We don't mind at all getting calls from other hospitals across the country as to your patients here has this sort of issues. What do you think? That's one of our functions. So I think I've covered this, the misinterpretation of films, tapping and pumping. I will tell you one story about adjustment. There was a patient who came to us who had traveled around the country because their valve, and I won't name the valve, but it was an adjustable valve, kept moving. It was not trustworthy. It went from here to here to here to here. And they basically wanted to be removed and put another one in or something, because this one is flipping all over the place. Not too uncommon a concern, at least. It turns out the adjustments were not made in a way that was proper. I'll just put it that way. It was made with the patient up, and the recording wasn't horizontal, and issues that are very important when you do the reading. And when I did the reading the wrong way and the right way, I showed them the difference. And that, no, actually your setting is proper. It's just when you read it this way, it is not proper. So it's important to have people do that. So I'll end up here by just saying that during the long years of life, there may be times when you are in bed for a long time with a broken leg that you may need to have your system adjusted. There may be times when you are very active that you're drained more because of your activity. Your life influences how much you shunt. We can make adjustments and compensate for it as an average of what you do, but your life will affect how much you shunt. Weight gain, fluid collection in the abdomen, and pregnancy all can affect that. And it usually is benign, usually just as a matter of symptoms, and often, if you have an adjustable system, that we can get away with making just those adjustments. We have many questions in the lifespan about creating a family. I'll say that you may have symptoms, but very often we do not have to do anything during a pregnancy. Although we can, if we need to, we can fix a shunt safely in a person who is pregnant, and a woman who's pregnant, but it is rarely has to be done. So the bottom line is go for it. And I will not talk because the time is running out, but any questions about adjustments, there's good adjustments and there's bad features of adjustments. If you are around and your various doctors are going up and down in a shunt and it's not helping, then it's time for someone to really look to see if the whole thing is working and not do the adjustments. A question we may get from the audience is about magnetic fields, and I said I would put that at the end, that there are, let me just say, there are sensitive valves and there are insensitive valves, and it's listed here. The ones that are still sensitive right now to magnetic fields, like an MRI specifically, are the Strata and the Codman Hakim. The other ones, and most of the new generations of valves that are coming out that are adjustable, you can go and get an MRI without it changing. And so finally, in summary, find a knowledgeable team, stay connected, keep and organize information and images. Do that yourself as a personal responsibility to help the doctors. Go with your gut feeling of when to come in and go to the nearest with progressive symptoms and enjoy. Enjoy your activities, your travel, and family. Thank you.
So if you could write down any questions on the cards, and Annie will be collecting them. As I mentioned earlier, because we are recording, we want to preserve people's privacy, so we'll be reading out all the questions. Maybe while you write, I will ask the first one, which is, you both emphasized the importance of staying in touch with your neurosurgeon and your team more generally, your neurologist in particular. And you said that includes regular contact. Can you give us a sense of how frequent that means and what you think about the need for regular imaging?
So the answer
if everything is going fine.
If everything is going fine, and the answer is always context dependent. Part of it is how comfortable is the patient and the family with the interval between visits. Part of it is whether we think we're actively intervening. If somebody is well and they're asymptomatic, then I generally will say once a year. If somebody's a little anxious that that's too long, we can go 6 months, or I say, you know, if you're worried, you can always come back sooner. A one-year appointment doesn't mean that you can't come back earlier. Some patients who have never had a shunt and have large ventricles and are asymptomatic, we may go to every 2 years. As far as imaging goes, generally speaking, if somebody is new to my clinic and they have not had a scan for a while, I'll get one as a baseline. But again, if everything is well, every 2 years or so is probably as often as I will do it. In some instances that will be a CT scan, and other instances that will be an MRI scan. And I think you may need both, and the reason for that is that although you can compare a CT to an MRI scan, there are important differences in the techniques, and it's often easier to be sure you're comparing a CT scan to a CT scan or an MRI scan to an MRI scan. If we think things are changing and becoming more active, then we'll have more frequent appointments.
I agree, except to say that what we also emphasize, while we may say 2 to even 3 years if a person is doing very well may be acceptable, if it's acceptable to the patient, we emphasize that there's a low threshold that if you have a concern or problem during that time, you can come back earlier. All you have to do is basically call us. But if we saw everybody, you know, with 6 months intervals, we in a sense wouldn't have time in our clinics to see the people who need our help that month. So what we say is, if you're doing well, 2 years may be fine, but call us if you have any problem.
Maybe as a follow-up to that, for those with VA shunts, could you talk a little bit about the role of the cardiologist? That's a question that came in, and should the cardiologist be seen regularly too?
Sure. So you all know the history of the vascular, they call it atrial, because they end up often in the atrium of the heart, or cardiac, or vascular shunts. They were actually the original shunts that were put in to infants, but because infants grew, it was very awkward. We had to keep putting other catheters in. So this is a catheter we've known for a long period of time, and has been used more or less over the last decades. The role of the cardiologist is the concern of chronic infections or growths at the end of the catheter. We know from long experience with vascular shunts, especially in Europe where they tend to use them, some groups tend to use them even more than us, is that there can be what we call a shunt nephritis, a chronic infection which sheds off proteins which affect the kidney. I'll get a call from the nephrologist saying, we have something going on with the kidney, the person has a shunt. If I hear that, I know that that's a problem. It can also cause vegetations on the valves and in the heart. It can also shed some of these growths and cause small emboli in the lungs. Now, these shunts do this rarely enough that they are still utilized quite a bit throughout our country and through the world, but they have to be used with people who know that that is possible with those kinds of shunts. And cardiologists who realize if there's a long-term catheter there, that you have to do an ultrasound, an echo, to be able to look and visualize the tip to make sure that there's no growths or granulations that might be there. So there's a role for the nephrologist, for the cardiologist, for the pulmonologist, because vascular shunts can involve these other systems.
So I would add to that I think the mistake that many physicians make, those of us in the field of neurology and neurosurgery, is to tell you that we've put the shunt into your heart. And that's not where the shunt is going. It's actually going next to the entrance to the heart. So if somebody's standing outside that door, they're not in this ballroom. So that's the analogy there. And the fact is that at least in contemporary practice, trouble with VA shunts are uncommon. And so my perspective, having dealt with patients with all sorts of shunts, is if you're well and you have a VA shunt, I don't necessarily see a reason for you to see a cardiologist on a regular basis unless you need a cardiologist for some other reason. But if you have had difficulty from the shunt, and as Mark said, there can be clots or growths or other things there that could get you into trouble, then indeed you may need a cardiologist or another specialist to be involved. And of course, if you have a VA shunt and as you're getting older you happen to develop cardiac problems, which can happen to you independent of the shunt, it's kind of good for your cardiologist to know that yes, I have a shunt there, and they can touch base with the neurosurgeon or the neurologist providing care to you.
While we're talking about VA shunts, let me just mention one more thing or two more things, is that often the neurosurgeon, without going to the cardiologist, will order tests every maybe 2 years or so, just to make sure that there are no growths developing. But importantly, from the everyday perspective, is the big difference from the patient standpoint in a vascular shunt is when you get your teeth fixed, or when you have an abscess in your foot, when you have anything which will push a lot of bacteria into your bloodstream, you need antibiotics, because that bacteria that's flying through the bloodstream will stick to the catheter that's in the vascular system. That is not true with peritoneal catheters. We get calls all the time. I'm going to the dentist, or I have an infection. Do I need antibiotics? If it's a ventricular peritoneal shunt, you do not. If it's an atrial shunt or vascular shunt, then you do.
Okay, I'm sorry, could you write your question down?
It's just related to the VA shunt. I just want to know if they recommend aspirin for people with VAs.
Do they recommend aspirin for people with VAs is the question.
I will tell you that we no longer do, no.
Let's wrap up real quick on this question of regular follow-up, because there's a question about ventricular pleural shunts, and just tell us real quick whether those people should regularly see a pulmonologist.
Usually that is not necessary, but a chest x-ray will tell you about the little bit of fluid that you actually expect to see with a pleural shunt. It tells us the shunt's working. However, with that same film, we could see no fluid, which may make us suspicious it's not working, or see too much fluid, which means it's not being absorbed well. So usually the symptoms of the patient and a chest x-ray is all that's needed to follow up a pleural shunt.
Right.
Thank
Again,
you.
only if you have trouble do you need to see a pulmonologist. And some patients do, and we're caring for them together.
Okay, let's move on to the issue of emergencies. A couple of questions on that. First, we saw that quite a few people go decades without having a failure, and there are people like that in the audience, obviously. Can you talk a little bit about how scared they should be about an acute failure, and how acute is acute? How quickly do they need to act? And as a follow-up to that, maybe you can handle both of these at the same time. You mentioned going to the ER if there's an acute onset of symptoms. Could you explain how the local ER would stabilize the patient without touching the shunt, just as reassurance and persuade all of us not to bother to drive the 3 hours to our own hospital? So, go ahead.
So, when I was in medical school and in residency and rotating through the emergency department, we were taught that the definition of an emergency is when the patient thinks it's an emergency. Now, I'm old enough, this was before they had walk-in clinics and so forth, but I think that is still true. And in some areas of the country, the emergency department may be the only place that you can go if you're worried that something is wrong. Now, the sociological aspect of that is that you may get labeled a frequent flyer by the emergency department, and that's not a fun term, that's a pejorative term, particularly if 9 times out of 10 it turns out to be nothing. And that in part I think is a reason to have an ongoing relationship with a neurologist or a neurosurgeon, because we may be able to help you to figure out, you're going to the emergency department a lot, maybe these symptoms are okay, but other symptoms should be worrisome. So to help you together with us learn what is an emergency and what isn't. And I always tell somebody, I'd rather have you go to see the doctor and find out it's nothing than to whistle in the dark and get into big trouble. So there's a balancing act that's involved with that. I started my career as a neurological intensive care specialist, so I've had many patients transfer from one hospital to another under emergency circumstances. I think how much the other hospital does depends in part on how sick you are when you're in that emergency department. And it may be that they have to do something to save your life and stabilize you for long enough to be transferred to a larger institution where additional care can be provided. Oftentimes there will be a conversation between the physicians to understand whether that's necessary or not. We have to understand how long will it take you to get from there to here, and we have to know the capability of the transporting team in that whole process. And a good transport is a safe transport and a stable transport. And sometimes you actually have to delay the transport and get the patient stabilized in one institution before transfer to another institution.
So what is stabilization? What do we mean by that? It could be something, as non-invasive as pumping the shunt and getting a blockage, which is transient going. It can be more invasive in terms of a shunt tap. Presumably if it's a hospital that does have neurosurgical care, most general neurosurgery training can tap a shunt, and they could take fluid off and greatly relieve an emergent situation of a more chronic situation where there's a bit more time. Sometimes that you can, just with a 1 centimeter incision, take out the distal part of a shunt, so it comes out kind of like an IV line. And therefore, you can get away from any blockage that might occur down below. Temporizing so that it's no longer an emergency, has to be fixed, has to be reinserted, but is no longer an emergency. If you cannot get fluid either in those two ways, and the problem is the catheter on the inside, then you have to do something more invasive. And that might mean in the emergency room or in the operating room, putting another ventric externally in to drain emergently. Now, you might say, well, that's an operation and I don't want to have that done except at hospital X. However, if that needed to be done when you arrived at that emergency that was closer, that probably would be very important to your health and life that it was done. And after that, after the fluid is drained emergently, we will, of course, can resume care either after they've internalized, or even sometimes we get patients and we internalize and put a shunt in afterwards. So there's various levels of tapping, externalizing, or sometimes putting in a new shunt, or just going and doing a revision if needed. But if they needed to do a external ventric emergently when you got in, then it's in a sense a good thing you went.
We are over time already. I'd like to, there are a bunch of very specific questions that came in. Would you guys be happy to stay around for a few minutes and have people come up and pick your brains if you have time?
Sure, and I'll give the caveat that we always give at this conference, which is that for most of you, we are not your physician, so we can't give you specific medical advice. We can give you some general thoughts on how to respond to things, but we're happy to have those conversations with you.
Can I ask one more general question, which I think may be of interest to many people then, and I apologize, we'll go over time. Feel free to leave if you have other things. There's a question that came in about changes in hormone levels and changes in symptoms. With a specific reference to menopause, but I think this is relevant over the lifespan for both women and men. So can you tell us a little bit about, whether we should be thinking about hormones when we look at how shunts are functioning?
So the first inference that I'm going to make is that this is in reference to headache. And I'm not hearing anybody say no. Okay, so, it's a pretty good guess because I've gotten that question before. So if the issue is with the hydrocephalus and the CSF circulation and the shunt, I will say that to the best of my knowledge, there's not a relationship. However, there are some headaches that change with hormone levels. And for women and for men, to state the obvious, those would be different hormone levels. But this is the circumstance where I would engage the care of a headache specialist to try to understand, is that relation there or not? And as I said, I'm not a headache expert myself. I know enough that those relationships can occur, but I don't know enough to tell you exactly what they are. Again, this is why having the right specialist for the right problem is so important.
Okay, thank you so much, Dr. Williams, Dr. Luciano.
Thank you.
That was great.
Thank you.